Well, everyone who's tuned in, thank you for joining us. My name is Dan Brown with the College Diabetes Network, Program Manager. We are super, super lucky to be joined today by George Huntley and Stewart Perry, who both have many, many years between them of diabetes advocacy and leadership. Right now, they both serve on the board for the National Diabetes Volunteer Leadership Council. And there's no one else in the world that I could imagine being a better expert to educate us all today on the issue at hand. So I will let them introduce themselves further and kindly get out of their way so that we can get started. They're going to have a presentation that I understand is about half an hour long, and then we'll have some time at the end for questions. So if you have questions, we ask that you please put them in the chat that you should be able to see down at the bottom of your Zoom window there. I'm sure we're all experts on Zoom at this point. Again, we'll do questions at the end and hopefully wrap up around 4:45 or thereabouts. So without further ado, George and Stewart, thank you so much. We will let you take it away.
Thank you, Dan, and welcome everybody. Thanks for having us. I'm George Huntley, and I am the current president of the National Diabetes Volunteer Leadership Council. I'm also a person living with type 1 since 1983. I stopped doing the math on that, so it's been a while. I have a sister, niece, and great nephew also with type 1, so I understand how critical insulin is to keeping all of us alive. And I am a past national chair of the board of the American Diabetes Association, as is my esteemed colleague Stewart. In my day job, which kind of plays into this topic today, I'm the CFO, Chief Financial Officer of a professional services firm based out of Indianapolis, Indiana. And in that role, I have been a plan administrator of a self-insured health plan for about 20 years. So I know the insurer side, the plan, the employer side of the equation is also having been also the patient side, using insulin, buying insulin, et cetera, through the plan. So that's kind of my background in going through this, and I'll let Stewart, my good friend, speak for himself as he does well.
I'm not sure I do it well. Hi, everybody. Thanks for tuning in today. Dan told me I couldn't use my radio voice, so I go and speak to you just like that. I am Stewart Perry. I have spoken to many of you before, I'm sure. I'm a great fan of CDN and all the things and the good work that CDN does. I serve as vice president with Mr. Huntley on NDVLC. I'm also vice chairman of DPAC, and I serve on the board of Children with Diabetes. I have type 2 diabetes. My father has type 2 diabetes, and my mother has type 2 diabetes, both of which are insulin dependent. My son, who's actually 34 years old, has type 1 diabetes. So I have been doing diabetes and diabetes advocacy for over 30 years. It's a pleasure to be with you today. And that's enough about me. George, why don't you start the program?
I will do so, if I can figure out how to make that happen. I apparently failed at that. Why did that not move? There we go.
There we go. That's always nice to have the two oldest guys running technology on the call.
Gary.
I have a wood-burning computer myself in front of me. So our objectives with this call are defining advocacy. Who are the fuss makers? What do we want to make a fuss about? Insulin prices and other things. How to make a fuss. It's easier than you really do think. And are you ready to make a fuss? So let's start out with the first one. Let's talk about who are the fuss makers and how do we define advocacy?
And so I'm admitting people, and while I admit people, good heavens above, it does stop.
Don't worry about it, George. I'll admit people. You just go on with the slides.
Are you able to do that?
Yes.
Well, how about that? I'll let you take over that responsibility because it's stopping this. So who are the fuss makers? So the definition of an advocate, a person who publicly supports or recommends a particular cause or a policy, one who pleads the cause of another, one who defends or maintains a cause or proposal, one who supports or promotes the interests of a cause or group, someone who makes a fuss. So if that is a word it's a four-letter word, but it's a fun four-letter word, fuss. So are we able to make a fuss? Are you ready to make a fuss? Are you a fuss maker? And what does a fuss maker look like? Well, that depends upon what time of year it is. Is it before the lockdown or is it after the lockdown? I'm kind of getting close to that after look, but the fuss maker could look like you. So hopefully you've got a mirror, you can look in the mirror, and that's you. You should be the fuss makers. So any questions on any of this stuff, please put a chat in there. Hopefully there's not much of a question on this, but as we go, I know Dan said we'll make some questions at the end. We'll take questions whenever you want to send them. So now we'll talk about what to make a fuss about, and insulin prices and the other hot topics. And some of the other hot topics will actually be in our Friday Fuss Making 102 section, but we want to tease that a little bit because there are a lot of things that you want to make a fuss about. And Stuart, do you want to take?
Sure. So today, let's talk about what's going on today with rising insulin cost, and that's the first thing we're going to talk about when we're here. So,
want me to keep going?
Yeah, just keep going. So let's talk. The three things we want to address on this call are what's the problem, how we got here, and what can we do about it. So what's the problem? Next slide, George.
Working on it.
So high costs lead to dangerous rationing. Anybody on this call that has type 1 diabetes maybe or may not has talked about cost-related insulin underuse. Rationing. That's another big word for rationing. 1 in 4 patients surveyed at leading diabetes clinics have said that they are rationing insulin due to cost.
And if anybody on the call willing to say, have you ever had to do this yourself, or do you know of anybody who has had to ration their insulin or cut back on what they were using because they were afraid of the cost? Pop that into the chat. That would be, but it may show up with your name, so I'm a little afraid of that. But if you're willing to share a story, sometimes those are powerful stories because it's happening far too frequently. And that's what got us moving. Why ration insulin when it's covered? So you've got people who are covered by insurance are rationing their insulin. That's one of the things that I think is so upsetting in this environment where I have insurance and I still can't afford insulin. How in the world is that possible? Well, first off, it's subject to the deductible. So you're in the deductible period and you're not getting the benefit of the price the plan's negotiated. You're paying list price in the deductible period. That's happening to a lot of people. That's not a good thing. There could be an administrative barrier in a plan that you're covered with. They may cover Humalog, but not Novolog. They may cover Lantus or Maslog. So your brand may not be covered. So if that brand is a problem, you either have to switch or you're going to pay, again, a higher price. You could be waiting on a prior authorization for refills. Maybe you've got it and everything was fine. You paid your price, but you dropped it. Or maybe you left it in the car and in the summertime and it's no longer effective insulin. I'm sure that's never happened to anybody, but trust me, in a few years, it will have happened to you at least once. there could be other reasons why you don't want to, you just can't have the money. You don't have the money to do it. So rationing happens all too frequently. And $2,865 for insulin, I mean, that is a lot. That's for a 90-day supply for this person, but that's a lot of money. That's a lot of money. So, how did we get here? What happened in the U.S. healthcare system? And there was a lot of moving parts that got us here. First off is the increase in high deductible health plans. High deductible health plans came in primarily through the Affordable Care Act, but they came in and became a mainstream insurance product. And by their name, they're high deductibles. And part of the high deductible health plan law was that pharmacy was included in the deductible. Prior to this, pharmacy was often outside of the deductible and people would have been on copay the whole time. But when high deductible health plans came into play, in order for them to be tax deductible, pharmacy had to be included in the deductible. And that was a problem. Now you also have an increased use of coinsurance versus copay. So if you don't know what coinsurance is versus copay, copay is a flat amount, $35, $50 for the prescription. Coinsurance is a percentage of the price. So you could be paying 30% copay, a 25% copay, a 40% copay, depending upon where you are. But the point is, it's a percentage. So it's a percentage of what? So in many cases, if it's the percentage of list price, you're now paying 30% of a $300 vial of insulin. That not being my strength, that's 90 bucks. That is a lot higher than a $35 copay. So you may be thinking, I've got 30% coinsurance. That's really not as cheap as it might sound. So you've got all of those three things happening. And then, oh, by the way, the list prices are going up and up and up through the roof. And we've got a slide coming a little bit on what's happened there over time. But as list price goes up and up and up, and now you've got more people subject to the deductible, more people paying the list price during that period, or a co-insurance as a percentage of the list price, a lot of bad things happen. And then Stuart's best friend, the pharmacy benefit manager, who is the folks driving I'll let you grab that, Stuart. The folks driving the higher rebates and the discounts. And we've got a very simple slide coming next that will talk about how all of that works, because it's fairly self-explanatory. And you were hoping to be done by 8 o'clock tonight, I know. But we will talk through what that is and how those folks work. And one of the key things that they're doing here is they are making these formularies exclusive. So they're holding the pharmaceutical companies a little bit hostage, because they have to get access to the formularies to sell into the insurance plans, and they will let one drug in but not the other, so they can get the largest or the best rebate possible. And Stuart, any questions? We really could just stop here.
If anybody, I'm sure that everyone on this call has heard that insulin is cheaper in Canada or Mexico. You may have experienced it yourself. And everybody wants to know why. If you were to reach up to your computer screen and put your hand over the whole left side of this screen, where George has his cursor. I've tried to take this cursor away from George and I can't do it. So the whole right side of the screen is what you see everywhere but the United States of America. The left side of the screen is what the United States healthcare system adds in. So let's quickly, I'm going to walk through what happens on the supply side and let George kind of talk about the money side, because as a CPA, that's what he's good at. Up at the top is the consumer. That's you. You go into the pharmacy or through a mail order, and you take a prescription for your insulin or any other drug you're on. The pharmacy then, through their supply chain, either through the drug wholesaler or directly from the drug company, depending upon how big they are, gets that vial of insulin, and they give it to you. Now, as you can see, the drug company sometimes sends it to a wholesaler. Wholesaler sends it to the pharmacy. You then pay your deductible or your copay, of which the pharmacy then pays the wholesaler or the drug company. Sounds pretty simple. Actually, it is. It's the way we buy everything else in the United States. Bread, milk, gasoline. Somebody supplies it to a supplier that then we purchase it. Sounds simple, and it is simple. The problem is the people on the left get involved when it comes to money. So, George, why don't you cover the money part of this?
Sure.
Because you know how upset I get, and I'll have to close down my camera because my face turns red.
That's true. That's true. So what happens here is you've paid $300 because you're in your deductible period. So let's say you're buying one vial of insulin and you've spent $300, and the pharmacy is going to keep a little bit of it, and it's going to go down, and the drug company is effectively getting $300. The drug company is then sending about $230 to the pharmacy benefit manager. I will say that again. The drug company is sending $230 out of the $300 that you've spent to the pharmacy benefit manager. The pharmacy benefit manager takes the $230 and is sending 200 of that, and these are rough figures, but they're pretty close. They're spending 200 of that back to the insurance company, or if you're an employer in a self-insured health plan like the one I am part of and administer, it goes to the company. So I work for my own company, or I don't own the company, but I work there. And if my plan is making me pay $300 for this insurance, for this vial of insulin, excuse me, my company just made $200 of profit because I went to CVS and bought a vial of insulin to stay alive. So I spend $300 and my employer gets a $200 check. Now it takes a little bit of time for that to happen, but that is in fact how the money flows. And if it wasn't to my employer, if it was a fully insured plan, it would go to Blue Cross Blue Shield or Aetna or Cigna or United Healthcare, whoever is the insurance company if it's not a self-insured plan. These monies go through to the insurance company, and the insurance company is using that money, or the employer, to keep down your premiums. So
wait a minute. Whoa, stop. I don't know anybody whose premiums have gone down, George. So how is this keeping the premiums down?
It isn't. The fractional amount that is keeping the premiums down is so minuscule. But the other really crazy part of this is, in this scenario, the sick, which is unfortunately us, are subsidizing the healthy. So our money has gone through, we've paid full list price for the vial of insulin. It's gone up, it's made its way as a profit to the insurance company during this deductible period. And they have used it to keep all of the people who don't have diabetes, they're keeping their premiums down. They haven't really kept, you don't even notice it. So why is that fair? And the short answer is it isn't. But that is in fact what's happening as we go through. And one of the things NDVLC we've done is we go actually to employers, and we partner with JDRF on this, to have conversations with self-insured employers to make sure that their plan design doesn't expose the participants, the insured, to list price. Because this is something where the employer treats the pharmacy benefit manager as a vendor, as someone they're buying from, which is in fact what they should be. They can dictate in that contract that please pass on these rebates at the point of sale to the consumer in my plan. And if they do it, then you're not subsidizing the healthy, but if they don't, you're paying $300. Yeah.
So George, what this chart is showing, and this is from the American Diabetes Association, correct?
Correct.
What this chart is showing is that the drug companies not making the profits that everybody thinks they are.
That is correct. I'm not saying they're losing money on insulin. They're not losing money on insulin, but the bulk of the money that you're spending for that vial of insulin is actually going on this left-hand side of this page. That's where 230 of the $300 for the vial is going.
So George, why don't I just go in and say I don't have insurance, and I can get that for a cheaper amount?
Because the reason why the list price is so high is that the pharmacy benefit manager is holding the drug company a bit hostage. And you can say, how can you hold a multi-billion-dollar company hostage? The pharmacy benefit managers, and there's about three, there's really four now, but there's 3 or 4 that have 80 to 85% of the US market. You're talking about Express Scripts, you're talking about CVS Caremark, you're talking about Omni, which is part of United Healthcare. Those guys have about 80% of the US prescription market. So if the drug company wants to get access to 80% of the prescription market in the US, they have to bid on how much rebate they are going to provide the PBM during that, for this privilege of selling their drug. And it's an all or nothing game. So if Lilly won't give a rebate, Novo Nordisk will. If Sanofi won't give the rebate, Lilly will. And so the amount of market share and dollars that are being played with in this is enormous. And there is no way the drug companies can get out of this. And the pharmacy benefit managers are living on the piece of the rebate they're scraping off. So these pharmacy benefit managers, whose job it is to keep the prices low, have figured out a way to make money based upon the price of the drug. So they actually have a perverse incentive to keep the prices high. And let's just say that perverse incentive is working because the prices are very high and the net prices are not. So why don't I go to the next piece so you can see what we're talking about there.
Okay, so what this is showing, and if you go over here to the right, if I'm paying $300 for a vial of insulin, what the drug company actually gets is $68?
That is correct.
There's $230 difference. So somebody's got my $230. Who has it?
The PBM and the insurance company or the employer.
Why do I not feel good about that? So George, I'm sorry, from this slide shows from 2012 to 2017, the net price of insulin has actually gone down but the list price, what all these people on the call are paying for insulin, has doubled, or almost tripled, right?
Almost tripled, that's correct. That is what's going on while high deductible health plans started to really take charge and take root. So they're playing this game while high deductible health plans are really kicking in. So what's really caused the advocate voices and everybody to be screaming about this, and it's good that we're screaming, because we should be screaming, because now even the insured are paying $300 during the deductible. And the uninsured used to be the only ones that were, faced with this kind of a cost. Now, with the way the insurance plan designs have happened over the past 5 to 10 years, you're now looking at a scenario where people with what they think is really good health insurance are paying list price and are having to ration drugs, even though they've paid an exorbitant amount of money for the premium itself.
I think I should have made sure I took trigonometry in school. This is crazy. This is backwards to any business model, except for the PBMs, that I've ever seen.
Well, math's important. Now, anybody out there, hopefully you've studied math. You can see the slide rule and the guy. This is good stuff. Okay, I'll keep going. I'll keep going. Math's important. Recently, have passed to cap copays on monthly insulin prescription. How does it fit into this system? Are PBMs losing cash because of this? So I'll get, and we're actually going to talk about this specifically in a couple of slides, but I will say, yes, they are effective because especially I believe they are going to be effective for the uninsured. And Stuart, you want to talk about when a state passes one of these, the state only has authority to do certain pieces.
Yeah, and Allison, that's a great question. So I'm assuming everybody has got their chat on and can see the question Allison asked. George talked about employer plans and he talked about health insurance plans. When a state passes a transparency legislation that limits the copay of insulin, it only affects what's called state plans. And state plans are individual plans that are administered by the state. Also, it normally will affect the state employee health plans, but it does not affect 70% or 75% of the people who get health insurance, because they get their insurance through either an employer-based plan or they get them through an association plan. And those are all governed by what was called ERISA, which is a federal government rules. Thus, when a state does this, they're only covering about 20 to 25% of the people that have diabetes in the state. Now that's better than zero, but it doesn't really help. Most people continue to get high deductible health insurance from an employer or through a group, and you end up continuing to pay list price through your deductible. So those state plans, and the PBMs are losing a little bit through this legislation, but not much, because most of those plans the PBMs don't control and frankly don't care about, because there's not enough people in it. I hope that answers your question, Allison.
So let's talk about, great. Let's talk about what price am I paying and why is this so insane?
Good question, George.
Yes, sir.
No, go ahead, George.
Okay. So I could be paying list price for, and I believe in this case, we're talking about some pens, 5 pens of Lantus, $442. This was earlier this year. Or I could go on GoodRx and save a piece of money for $357. Or I could be in a coinsurance plan where I'm paying 30% coinsurance, and that would be $133, which is certainly better than either of these other two options. Or I could go to a manufacturer assistance program, patient assistance program, and pay $99. And in some cases now they're even lower. But most of them will, $99, if you're paying more than $99, you could be going to these manufacturer assistance programs. And one of the problems with that, and we'll talk about that in a second, is you don't get credit to your deductible for doing that, but it's a lot cheaper than $442. Or I could be in a plan that gives me a standard copay of $50. Express Scripts, one of the evil PBMs, is understanding that they really need to stop this because they're all taking a massive hit, and they're starting to wake up. And the advocate voices are actually starting to get heard here. So Express Scripts has come out in this year with a $25 plan, where if you're covered and that the PBM in that plan is Express Scripts, you'd pay $25 for your prescription of insulin for that month. CVS has gone on record saying, we're going to give insulin away. We think it's so important that we're going to put these RX0 plans for insulin and give it away. The problem is the insurance company or the employer has to actually select these plans. These aren't every plan that Express Scripts offer. It's not every plan that CVS offers, but you actually have to, you have to pick that plan as the employer or the insurer. And that's not necessarily what everybody's picking right now.
Okay, so help is available is the name of this slide. And George and I have been doing this for a long time. And all the organizations that we represent, what's in red is one of the most important things. No one should have to ration life-saving insulin. It's okay to ask for help if you're struggling. So how do you get help? The first thing is, as George talked about, do the math. Understand and maximize your health insurance coverage. If you get it through your parents, meet with them and meet with the administrator of the program, either on the phone or in person. If you buy health insurance, ask those questions. Ask for cash prices. Go to the pharmacy and say, if I paid cash, how much would this be? Use the retail discount programs that George talked about, GoodRx and those others. Enroll in manufacturer discount or patient assistant programs. Check at member warehouses, Costco, Sam's Club. NDVLC did a study and showed that Costco and Sam's Club tend to have lower prices for insulin and other drugs. Find a community health center or a low-cost provider. Community health centers use 304B pricing, and they get it much cheaper than somebody else. If you're getting it from an employer-based plan, like George says he administers, talk to them about insulin. Talk to them about what you're paying and why, because they may not even be aware of it. And talk to your diabetes care team about lower options as well. ndvlc.org/reduce has got a lot of information. So now the uninsured and underinsured, these three insulin companies have all come out with brand new patient assistant programs. Lilly's at $35, Novo's at $99. All these sites have now got it to where you can get your insulin for much less. That doesn't even talk about going to Walmart and getting human insulin for $25, which all 50 states now will let you do without a prescription. So there are plans available, and these companies have set up patient assistant programs. George, did you not download the card from one of them immediately?
Yeah, I got the Novo card. It took me about 5 minutes to download it. I will say, guys, if the advocacy on the price of insulin has come a long way in the last 3-4 years. It's been really, really, really hot. The fact that you're seeing these prices out here, nobody should be paying list price ever. The problem with going to a manufacturer assistance program is that you will not get credit for your deductible. So if you're in a high deductible health plan, the $99 that you're spending or the $35 that you're spending does not go towards your deductible. But let me say, it is far better to pay $35 and take your insulin and be healthy than to pay $400 for it and have that be part of your deductible, but you're now rationing your drugs. The economics of it are starting to get to be a no-brainer. If you have a friend, if you yourself are uninsured ever, go to these scenarios, go to these manufacturers and get your insulin from them through the process. It takes a little bit to go through it, but they're getting a lot easier. The 800 numbers are staffed. They're multilingual. If you're paying list price, you're doing it wrong. And so you need to make sure that we're really advocating out this, and you all are talking to people who may be into situations where they're struggling. One of the purposes of this presentation is to empower you guys with knowledge so that you can go out and continue to propagate this information, because you're not going to see a TV ad on this. It's just something that we need to make sure we're all doing. So we've come a long way. We're just not quite there all the way to the end zone yet.
And right now, when the COVID-19 crisis, George, I think they're giving insulin at $0, are they not?
Some are. I mean, Lilly came out with 35. Medicare came out with $35 insulin. So you can, even through Medicare, is coming out next year with $35 insulin. A lot of progress has been made on this, and it just means we got to keep making a fuss, because making a fuss works. If it didn't work, we wouldn't bother doing it, but it actually does work. So let's talk about what's all the fuss about. Federal level cost of insulin issues, state level. So we promised to get you out of here by 9, or maybe it was 8. I'm sorry. We'll try to make 8. Point of sale rebate pass through, which is, you know, the holy grail of, for heaven's sake, why I have paid. I'm in an insurance plan. I'm paying a premium. Why in the world would I have to pay list price and not get the benefit of the discount or rebate that the plan has negotiated seemingly on my behalf? If I go to the doctor and have an exam, if I have a test run, if I have a procedure, I will always get the benefit of the discount the plan has negotiated. But in drugs, it's not the case always. So we're looking to make this a federal mandate. Thou shalt pass through rebates. The Trump administration actually tried to do this. I'm not necessarily a fan. I'm just saying they tried to do it. It got shot down by the CBO, by the Congressional Budget Office. They scored it as something that was going to cost billions of dollars, because the accountants in the Congressional Budget Office did not comprehend that if you dropped the rebate and you passed the rebate through, that in fact the PBM might actually negotiate net price down to 68 instead of keeping that rebate through. They really did not comprehend that you would just lower the price scheme altogether, and therefore it wouldn't cost the government billions of dollars. So it's a big one. It's something we're still fighting through. Chronic disease management has been exempted from deductibles in high deductible health plans. That happened last summer. It has been just last July. That is huge, because prior to that, it was not given that an employer could put insulin and have insulin bypass the deductible, because in a high deductible health plan, pharmacy must be part of the deductible. The escape clause on that is if it was a preventive drug, and there are certain drugs on the preventive drug list. Insulin was not specifically named on that list. Several employers we would speak to would have insulin on the preventive drug list, and therefore people were automatically just paying copays from January 1. Others were saying, hey, it's not on the list, so I can't just automatically do it, or I could risk the tax exempt status of my entire health plan, which would be a very big deal. Last summer, that issue was resolved, and now they can do it. So again, making noise, being a fuss maker works. We are moving the needle. There's a lot of things in play. And one of the things that we'll say is we expect next year to be a big year on health reform debate. Once we get the presidential election is done, you get the new Congress in 2021, we expect healthcare and healthcare reform to be a hot topic again, like it was in the first year of the Obama administration. We are in fact working, NDVLC and CDN are working together with 9 other diabetes organizations in a working group to put together what do people with diabetes need and want out of this next round of health reform, so that we can go to Capitol Hill with a consensus statement of this is what we all need. So we're putting that together really as we speak. Those discussions are just now ongoing, so that we can have something to publish by the end of the summer. So stay tuned for that. We'll talk about it a little bit more on Friday, but stay tuned for that, because we need more advocates and we need more people. Once we have the consensus statement out there, we want to make a lot of noise. Let's talk about the state level of things, and I'll talk Indiana, and Stewart, you can touch on some of the other pieces. Indiana, only because I live here. Indiana was the only state in the union that did not have over-the-counter insulin, which if you don't know what over-the-counter insulin is, and hopefully you never have to, okay? Prior to 1996, the insulins were human analogs. They were not the current, they were recombinant DNA insulins that came out in the 80s. And they did not require a prescription. You could just go up to the counter and you could pay 25 bucks and you can get it. And in every state, and soon to be including Indiana, you can go get regular, which is the fast acting, which is not nearly as fast as what the current ones are. It's about an hour before it kicks in, or NPH, or the long acting stuff, which will take about 4 hours to kick in. You could buy that at the drugstore for 25 bucks a vial, roughly. Walmart would have it. And you can, again, as an emergency, people don't know these drugs exist. The doctors don't know these drugs exist. They're not a great answer when the more modern, really smoother drugs are available. But I stayed alive on these drugs for 13 years. And I will say it is far better than not being alive. The fact that people don't understand or realize that they're there, we worked hard to make sure that Indiana could actually have them. And we talk about that. So there's a lot of things on the state level. Stuart, you want to talk about some of the copay legislations?
Yeah, I mean, we talked earlier about the copay caps and what they do and don't do. Rebate pass-through has been introduced in a number of states, including Indiana and Kentucky, both of the states George and I represent. Rebate pass-through basically means those rebates we talked about get passed directly to the patients rather than going back to the health insurance companies. And then there's been some state-run insulin assistance programs. None of this is ever going to be fixed at the state level. It's going to take federal legislation to make it happen, to get it fixed. But states are trying to jump into the battle and try to get something done. I'm not discounting states and what they need to do, but once again, I think it's going to take federal legislation to ever get anything done in a real way.
The only thing I'll add to that will maybe twist that a little bit, if the federal government doesn't get rebate pass-through done, okay? If we wind up getting the commercial world, commercial insurance, everybody's paying $35 for insulin. If Medicare, which will happen this coming enrollment season for 2021, $35 prescription. If everybody's paying $35 for the prescription in the commercial or Medicare world, then most of the noise goes away, right? Everybody's pretty happy at $35, except for the 12 to 20% of America that are uninsured. And the 12 to 20% that are uninsured, if we don't fix the rebate pass through and mandate it across, those folks are still going to be paying $300-400 per prescription. And the piece of that will address that at the state level are these copay caps. So when the question that Allison asked, and as we think about what we may need to do moving forward, if the federal government doesn't do it, the states can impact what the uninsured pay in their own state. And so that may be a strategy that we're all going to have to go after. And we've run at those windmills before, and we'll go for it. So how to make a fuss? What happens next here? It's easier than you think. Stuart, you want to walk us through the process?
Sure. Fuss making, simple steps. I mean, it's pretty self-explanatory. We've got, I guess we're just visiting Indiana, George. We're not visiting anywhere else, but send emails, personalized emails. Get involved. CDN, I know, will send stuff to chapters every once in a while when they've gotten contacted about stuff, asking for participation. Go to ADA.org, JDRF.org, NDVLC.org, or DPAC, DiabetesPac.org. The DiabetesPac.org actually has the Affordable Insulin Project that you can go to as well and download worksheets when you're talking about your health insurance. CDN's getting ready to come out with a resource page about health insurance. It's excellent. The video's not too hot with it, but the rest of it is excellent. Get involved.
Because he's in the
What
race.
this slide says is to get involved. Do something. Tell your story. Tell your story to the politicians. Get involved and take action when you get the alerts. Stand up and be counted. Be a fuss maker. That's what this is all about. George.
Yeah, and 5 to 10 emails, that's a groundswell. 5 phone calls is a groundswell. Don't think you've got to be part of 100,000. A couple of times will make a difference. So are you ready to make a fuss? Do people know if I had a hammer, I'd hammer in the morning, I'd hammer in the evening, all over this land? That's really from protests from 50 years ago, but it resonates. So we appreciate your attention to this and your participation. We're hoping that you're ready to make a fuss. Any questions that may pop up here? Anything that's on your minds? Happy to help. Happy to chat. And we do have we're giving a presentation on Friday at 4 Eastern again on the other topics that are not around insulin, but there's a lot of other things that you should be caring about too.
And we have unmuted your microphone, so if you want to ask a question, feel free. Right, Dan?
Right, yes. Thank you guys so much.